How's everyone doing? My name is Ulyee Choe. I'm a second year infectious disease fellow at the University of South Florida in Tampa. My topic today is going to be a review on HIV-2 infections. In a most recent edition of the Clinical Infectious Disease, there was a nice update on HIV-2 infections and some of the points I will be covering over here tonight. Let's start off with a case vignette. A 45-year-old African female who recently immigrated from Nigeria approximately 2 weeks ago comes to your clinic, to HIV clinic, to establish care. She was diagnosed with HIV in Nigeria in 2005 and has never taken antiretroviral therapy. On intake with the baseline labs, her HIV antibody ELISA was found to be positive, but her Western blot was found to be indeterminate. The HIV PCR viral load was undetectable at less than 20. What is her diagnosis? Well, obviously, given the title of the presentation, I'll be discussing HIV-2. But my next question would be, what is the reason she has this indeterminate Western blot and some of the unusual lab findings we see here? Again, these are some of the teaching points I'll be concentrating on this talk. So the goals of this talk provide a little background about HIV-2 infections, including the history, the origins, and the structure, and how the major differences between HIV-1 and HIV-2. Epidemiology, as certain parts of the world have higher prevalence rates of HIV-2 infections when compared to HIV. I'll go over the CDC screening guidelines and some of the other guidelines out there. I'll discuss a little bit about the diagnostic testing, including the EIA, immunoblot, and PCR viral loads, and some of the limitations they may have in the face of HIV-2 infections. I'll provide the most recent data on specific antiretroviral medications, as again, they have a difference in response when compared to HIV-1. And lastly, we'll also cover treatment recommendations that are out there, both by the DHHS guidelines as well as the other governing bodies out there. So a little bit about the history. As you're all aware, the HIV-1 infection is the predominant virus worldwide, causing AIDS. But a second strain, the HIV-2 virus, also exists. It was first identified in West Africa, in the country, I believe, of Guinea-Bissau in 1986. It was first discovered in the U.S. in 1987 in a West African woman who presented with CNS toxoplasmosis. Here's an interesting family tree on HIV, for HIV-1 and HIV-2. It's thought to have originated from the simian immunodeficiency virus from two distinct different primates, and this family tree on the left does demonstrate this. For HIV-1, it's thought to have originated from a SIV virus from chimpanzee species, Pan-troglodytes. And the major groups that you may be aware of, M, O, and the newer ones, N, and not listed here, P, appears to have come from 3 and now 4 separate transmissions. Similarly, in HIV-2, it's related to an SIV virus from the Sudi Mangabe monkeys, and has the two main groups, A and B, are thought to come from 2 separate transmissions here as well, and is in the blue in the in this schematic on the left. So the structure. When compared to HIV-1, HIV-2 is genetically and immunologically distinct, though they do share similar genomic organizations with a 40% nucleotide homology and a 60% GAG and POL homology. And again, like HIV, it can be broken down to different groups, A through A, but it is groups A and B that are the 2 major groups associated with human epidemics. So this is a key difference between HIV-1 and HIV-2. As I mentioned, HIV-1 is predominantly worldwide, but HIV-2 is found specifically mainly in West Africa, specifically in the nations of Guinea-Bissau, Gambia, Senegal, Cape Verde, the Ivory Coast, Mali, Mauritania, Sierra Leone, and Nigeria. And in these countries, the prevalence is as high as greater than 1% of the whole population that are seropositive for HIV-2, and and that equals about 1 to 2 million people affected with that are seroprevalent positive for HIV-2 infections in that region. though the recent studies have shown that the prevalence of HIV-2 in these regions are declining. In one study looking in a village in Guinea-Bissau, the prevalence, which was at 1990 8.3%, has been decreased 10 years later to 4.7%. Interestingly enough, the HIV-1 prevalence in this village did increase from 0.5 to 3.6%. So here's a map of the African HIV-2 seroprevalence for high-risk urban population. This in the green, with the places with a higher prevalence, such as Senegal, Mali, and even Ghana, even though I did not mention that previously, does appear in certain areas to have a prevalence as high as 10%. In countries like Nigeria, it can get as high as 2.5%, and even the Congo, the Republic of Congo, can have a prevalence of 0.2%, though less to the extent of the other countries, as I mentioned. So what about the countries outside of the Western African nations? Basically, there are certain industrialized countries out there that have a disproportionate higher prevalence of HIV-2 when compared to other industrialized countries. And generally, these countries that do have this disproportionately higher prevalence have strong historical and socio-economic ties with West Africa through civil wars, trade, and colonization. These countries include Portugal, France, Brazil, Angola, and even parts of India. And of these countries, it appears that Portugal is the one with the highest prevalence due to mainly the colonization of one of these countries, Guinea-Bissau. And in one study, it showed that HIV-2 was responsible for 4.5% of all cases of AIDS in that country. Similarly, in France, of the newly diagnosed 10,000 HIV diagnoses from 2003 to 2006, appears that of these, 1.6% of these were HIV-2. Other countries with a lower prevalence, such as United Kingdom, have a relatively small number, and studies showing that only 137 documented mono-infections, and as well as 35 dual or co-HIV-1 and HIV-2 dual infections. In the U.S., there's a relatively small number, though there isn't an exact number, since New York, for example, has been keeping track of HIV-2 since 2000. They've reported 62 cases. Keeping in mind that the last Census Bureau did report that 250,000 people from this highly prevalent endemic region in Western Africa reside in the United States, so these numbers could be higher and yet to be diagnosed. So transmission, the HIV-1 and HIV-2 share the same mode of transmission, namely heterosexual contact or sexual contact, blood-borne exposure, and vertical transmission, with heterosexual contact being the most prominent mode of transmission. And some characteristics that may differentiate it from HIV-1 is that the HIV-2 virus appears to have a lower infectivity. In one study, it showed that compared to HIV-1, the risk of heterosexual contact or transmission was only 5 to 10-fold. 5 to 10-fold lower in HIV-2 when compared to HIV-2. HIV-2 when compared to HIV-1, and 20 to 30-fold less in HIV-2. This is largely thought to due to lower viral loads. Though similar to HIV-1, HIV-2 produces a stable proviral infection, but does produce less mRNA. And another study out of Gambia showed that on the diagnosis of the diagnosis of HIV was made, the baseline mean viral load for HIV-1 was greater than 15,000, and that for HIV-2 was only 410. This viral load is largely due in part corresponds to the CD4 count level of the patient. Undetectable viral loads can be seen in up to 35 to 50% of patients. And in patients with greater than CD4 count, only 8% of patients have detectable viral loads. In CD4 counts less than 300, only 62% of patients have detectable HIV-2 viral loads. And even in AIDS-defining illness, only 53% of patients have detectable HIV-2 viral loads. So this is basically a disease of low viremia. Other characteristics, appears to have a longer asymptomatic phase and a slower progression to AIDS. For HIV-2, the AIDS-free survival after 5 years after seroconversion was found to be 100% in HIV-2 compared to 67% in HIV-1. And at least early on in the disease, there appears to be a decreased mortality, with HIV-2 having a mortality 2 to 3 times that of an uninfected population, whereas in HIV-1 you would have 10 to 20. As I mentioned before, generally these patients have, at least on diagnosis, higher CD4 counts. But it appears that once AIDS are to develop in these patients, they have the same mortality as well as the same risk of opportunistic infections. For those on treatment with treatment for HIV-2, there appears to be poor CD4 count recovery with treatment, something I'll mention again in the treatment portion of this talk. So looking at the CDC recommendations for HIV testing, it focuses on those that are at risk for HIV-2. So what they mention is the sex partners with a person from a country where HIV is prevalent, those prevalent Western African nations, as I mentioned, are known to be infected with HIV-2. Similarly, if they had received blood transfusions or non-sterile injections, including IV drug use, from these high-risk patients, testing should be considered, as well as children of women who have high risk for HIV-2 infections or are known to be infected. Other indications include people who has an illness that would suggest HIV infection through opportunistic infections or others, but whose HIV-1 test result is not positive. And also people whom HIV Western blot exhibits unusual determinate test band patterns, especially in the gag plus pole in the absence of the envelope. Regarding testing, a lot of the tests that we use for the diagnosis of HIV and even monitoring, such as a PCR, appears to not be as effective in HIV-2. This is due to, again, the differences in genetics and structures. For one, HIV-2 has a different capsid antigen from the HIV-1 P24 antigen, as well as certain antigens found on the envelope. Current FDA-approved diagnostic tests include uses enzyme-linked immunosorbent and chemiluminescent immunoassay methods. There's a lot of brand names that are out there using these methods, and they detect both HIV-1 and HIV-2, but does not necessarily differentiate between the two. Only one such test, the multi-spot HIV and HIV-2 rapid tests, is FDA approved and consistently does differentiate between the two viruses. But again, this is like both of the monospot as well as other tests are more like the ELISA or the EIAs and needs a supplemental confirmatory tests. Unfortunately, the supplemental HIV tests, including the Western blot or immunoblots, are not FDA approved. They're currently only available in reference labs such as Quest and Focus Diagnostics, as well as independently lab-developed HIV-2 Western blots as used in the California Department of Health. Regarding PCR testing, there is again no FDA-approved assays for the quantification of HIV-2 RNA. Again, it is more independent research labs, and there's no clear standardization. Certain HIV RNA assays currently available, such as the AmpliCore and the NucleoSense, may detect HIV-2 RNA, but not at a consistent level. Given these facts, the HIV-2 RNA level cannot generally be monitored, as is the standard of care of what we do in our HIV-1 patients, and rather it needs to be monitored more clinically and through CD4 count trends and/or decline. Moving on to treatment, there's a lack of large observational or randomized treatment studies in HIV-2 infected people, and this is due to that there's only, again, a handful of patients in US and in Europe, which do, unfortunately, the bulk of HIV tests worldwide. And again, there's a large portion of HIV-2 infected patients who do not demonstrate a detectable viral load, so some difficulties in monitoring. So going on to each individual antiretroviral medications, it appears that certain medications have different response rate to HIV-2 and does not necessarily correlate with the response we see in our HIV-1 patients. For example, the non-nucleoside reverse transcriptase inhibitors, the NNRTIs appears to be intrinsically resistant to HIV-2, largely due to the structure of the NNRTI binding pockets. And again, due to this fact, the use of NNRTIs is not indicated for HIV-2 treatment. Regarding NRTIs, it appears that the susceptibilities of HIV-1 and HIV-2 are similar for wild-type virus, though for HIV-2 it appears to have a lower barrier of resistance, meaning that there may need less mutations for it to inactivate certain NRTIs. Additionally, it appears that there are novel mutational pathways seen in HIV-2 that is not seen in HIV-1. One example is a failure treatment with thymidine analogs are not associated with TAM mutations. There's also a higher rate of mutation in the treatment naive, specifically the M184V and the Q151M. These may be due to naturally occurring polymorphisms or increased risk or rates of transmitted drug resistance. It appears on therapy that the HIV-2 virus may develop resistance at a faster rate, specifically the Q151M and the K65R. Which are both of these, which appears to be the main pathways to resistance for the NRTIs for the HIV-2. Despite the high preponderance of the K65R, it appears clinical studies have shown tenofovir to be the most effective out of this class. Moving on to protease inhibitors, again, the resistance occurs. There's, again, natural polymorphisms, so higher rates of resistance in the treatment naive. There appears to also be higher rates of cross-resistance mutations that across the PI classes, and again, there are novel mutational pathways not ordinarily seen in the HIV-1. Certain in vitro studies have shown that the potency of specific protease inhibitors are variable. The studies have shown that lower activity, there appears to be lower activity of atazanavir, nalfinavir, tipranavir, and pranavir, and endenavir. Clinical studies such as the ANRS CO5 HIV-2 cohort, as well as other studies, demonstrate that lopinavir boosted appears to be the most effective. One thing of note in this study showed that there was a high rate of this mutation known as ProV147A, which though is rare in the PI experienced patients in HIV-1 with a prevalence of only 0.14%. Those in the HIV-2 PI experienced patients have a prevalence of this mutation at 8.6%. This mutation essentially deactivates the lopinavir boosted. And in regards to other newer protease inhibitors, there's limited data on darunavir. Regarding other medications, such as the fusion inhibitors, ifluvatide, not recommended for the treatment of HIV-2 as there are in vitro reduced susceptibilities of 20 to 100-fold. Again, this is due to differences in the envelope receptors. Studies have the limited studies we have does show that integrase inhibitors, on the other hand, appear to be susceptible with the only one approved in this class right now, the raltegravir, as well as the soon-to-be released elvitegravir. Regarding the CCR5 antagonists, the only one in this class right now is maraviroc. The efficacy is unknown, and obviously there is no current HIV-2 co-receptor tropism assay. And another problem with this medication is that HIV-2, unlike HIV-1, which only has the co-receptors, the CCR5, the CXCR4, or a combination, it appears they have more receptors even on top of those, including the included CCR1, 5, the GPR15, and the CXCR6. So that may pose a problem with this medication. So when to start? Again, largely should be based on CD4 count and clinical status. There's no comment specifically on when to start by the DHHS guidelines 2009. But just to give you an example of how other groups do it, other groups' recommendations, the British HIV Association released recommendations regarding the treatment of HIV-2 in 2010. They recommended starting treatment at HIV-2 viral loads of greater than 1,000, as for this disease seems to be a pretty high viremia and can lead to progression of disease. They did not clearly specify what CD4 count, but they do potentially recommend earlier than what we do in HIV infections, and currently what we start is generally 350 to 500. The reason being is, again, on treatment for HIV-2, the CD4 appears to recover poorer. And to give you some numbers, the recovery generally for HIV-2 appears to be only 40 to 70 cells per microliter, whereas in HIV-1 it's 60 to 136. And again, the problems with monitoring, with the viral loads not being undetectable until CD4 counts are lower or less than 300. So what to start? The DHHS guidelines recommend starting a boosted PI regimen, but do not specify which specific medications. Most experts would recommend ritonavir, boosted lopinavir or darunavir, plus tenofovir and emtricitabine or lamivudine. One clinical study showed a pretty good response rate of 60% at 96 weeks with the Truvada and Kaletra combinations. Most experts, again, do not recommend all NNRTIs and afluvatide, again, as due to the points I mentioned, as they're intrinsically resistant, as well as the PIs that have shown lower efficacy, such as nelfinavir and pranavir and atazanavir. Get back to the British HIV Association from the 2010 guidelines. The example of their first-line regimen includes lopinavir, ritonavir with tenofovir and emtricitabine. The alternative being darunavir boosted with AZT. Second-line regimens, again, 2 NRTIs not listed, not of the ones not listed above, as well as lopinavir boosted, sequinavir, darunavir boosted, plus or minus raltegravir. Regarding the monitoring of treatment response, again, the should be monitored more by immunologic response and clinical rather than virologic, as the viral loads are difficult to obtain or interpret. The drug resistance testing are not commercially available, like almost every other test for HIV-2. Resistant associated mutations do develop commonly in HIV-2 patients on treatment, again with higher frequencies of the Q151M and the K65R on those on treatment. And again, the genotypic algorithms we use to predict drug resistance in HIV-1, such as the Sanford database, is not applicable in the HIV-2, as pathways and mutational patterns may differ. Lastly, talking about the HIV-1 and HIV-2 co-infections, it appears that 0.3 to 1% of HIV-infected patients are estimated to be dually infected. The mortality rates are similar to those with HIV-1 monoinfection. And the treatment, again, should be targeting both the HIV-1 and HIV-2. Should be more of a ritonavir-boosted PI regimen plus 2 NRTIs. And if treatment failure were to ensue, then the resistance patterns of both viruses should be evaluated simultaneously. And there's my references. Thank you very much.